For patients with multi-organ metastatic colorectal cancer, does tumor debulking in conjunction with palliative chemotherapy improve survival? Do physical restraints reduce coma or delirium in patients who are critically ill? How are out-of-pocket insulin costs for Medicare beneficiaries changing? This and much more on today's JAMA Editor Summary. Hello and welcome to our listeners all around the world. Today is Friday, March 20th, 2026. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hi Preeti, let's get started.
Hi Linda, let's start with the ORCHESTRA trial by Dr. Gutjes and colleagues, which investigated whether reducing the total amount of tumor, referred to as tumor debulking, in addition to palliative chemotherapy, improves survival in patients with multi-organ metastatic colorectal cancer. This Phase 3 multi-center trial enrolled nearly 400 adults across the Netherlands and UK, all with colorectal cancer and extensive metastatic disease. Patients were eligible if more than 80% tumor debulking was considered feasible via surgical resection, radiation, or thermal ablation. After initial chemotherapy was complete, patients were randomly assigned to either continue chemotherapy alone or to tumor debulking followed by chemotherapy. The study's primary endpoint was overall survival. After a median 32-month follow-up, there was no clinical or statistical difference in the median overall survival, which was 30 months in the group that received tumor debulking versus 27.5 months in the group that received chemotherapy alone. More patients in the chemotherapy plus tumor debulking group experienced serious adverse events compared with the group receiving chemotherapy alone, 53%, compared with 39%.
In the related editorial, Dr. Faki writes that the results of the ORCHESTRA trial should be used to avoid routine tumor debulking in this clinical setting. Systemic therapy should remain the standard, as surgery adds unnecessary risk without clear benefit.
Physical restraints are widely used in ICUs, mainly to prevent self-injury or inadvertent device removal. Yet the benefits are unclear, and restraints may increase stress and the risk of delirium for patients. Dr. Sonneville and colleagues conducted the R2D2 ICU trial to better understand the effects of physical restraints, specifically wrist straps, in adult patients receiving mechanical ventilation. In this multi-center trial, 405 adult patients receiving mechanical ventilation in the ICU were randomly assigned to either a restrictive or low-use strategy, in which restraints were avoided unless patients were severely agitated, or a liberal or high-use strategy, with restraints applied to all patients with daily reassessment. The main outcome was how many days patients were alive and free from delirium or coma for the first 14 days. Secondary outcomes included the incidence of self-extubation and 90-day mortality. The results were similar in both groups, with a median of 6.67 days free from delirium or coma in the low-use group and 6.3 days in the high-use group. The rates of self-extubation and 90-day mortality were also similar. The authors conclude that no clear benefit was found when using a low versus high-use restraint approach, supporting a more patient-centered, cautious approach to physical restraints in the ICU.
And in the editorial by Dr. Haynes and colleagues, the authors emphasize that restraint decisions should be individualized, noting that routine restraints are not needed for all patients receiving mechanical ventilation, and minimizing both physical and chemical restraint is important. They advocate that clinicians should consider potential harms, patient circumstances, and local resources when making these decisions. Preeti, what's in this week's research letter?
This research letter from Dr. Fang and colleagues examined insulin out-of-pocket costs among U.S. Medicare beneficiaries not receiving low-income subsidies. The study used 100% Medicare Part D prescription claims from 2019 to 2023, covering nearly 3.8 million beneficiaries with an average age of 70.7 years, all with at least one annual insulin claim. Researchers evaluated the out-of-pocket cost for a 30-day supply adjusted for inflation. They found the percentage of patients paying $35 or less for insulin jumped from 48% in 2019 to 75% in 2023, while mean monthly costs fell from $50.87 to $21.98, with large declines occurring after 2020, following the CMS Senior Savings Model and the Inflation Reduction Act. However, in 2023, 25% of beneficiaries still paid more than $35 per month in out-of-pocket costs, often due to prescription quantities not easily prorated to 30-day limits. Cost decreases were seen nationwide, but remained highest in rural Midwestern states. Overall, insulin affordability improved for most Medicare beneficiaries, but clearer guidance on prorating out-of-pocket costs to match the Inflation Reduction Act limit could further enhance savings.
Moving to the JAMA Viewpoints, Drs. Ulrich and Lurie take us through a historic overview of the FDA's transparency practices, highlighting persistent calls for increased public disclosure, from legislative changes starting in the 1970s to recent policy shifts, including the public release of critical drug approval documents. The authors assess what has worked, point to continuing gaps, and offer practical recommendations reminding us how agency transparency can strengthen public trust, accountability, and innovation in medical regulation. In another viewpoint, Preeti Bachina and colleagues explore whether AI tools, now integrated into the Electronic Residency Application Service, or ERIS, platform, are introducing new legal and fairness concerns, particularly around discrimination and transparency. The authors encourage the AAMC to implement stronger, enforceable standards to safeguard applicants and uphold fairness.
Linda, JAMA also published a couple of thought-provoking perspective articles. Dr. Wolf reviews the widening gap between U.S. life expectancy and peer nations, outlining the administration's sweeping policy changes impacting healthcare access, economic security, safety regulation, vaccine policy, and public health data. He calls for health professionals and organizations to speak out and safeguard evidence and assessment in an era marked by politicization and erosion of health protections. In a separate perspective article, Dr. Robertson and Professor Netter Epstein discussed the 9 bundled reforms in the Great Healthcare Plan proposed this past January. They argue that while the plan offers political appeal, its legal foundation and impact are narrow, with modest savings and limited benefits for most patients.
The new JAMA Clinical Guidelines synopsis by Drs. Matthews and Alexander reviews the clinical guidelines for the treatment of Helicobacter pylori infection, published in 2024 by the American College of Gastroenterology. The authors summarize these guidelines, which focus on treatment recommendations for both treatment-naive patients and those with persistent Helicobacter pylori infection. And this week's JAMA Clinical Reviews podcast covers peanut allergies. This podcast is a great addition to the recent JAMA patient page and insights article on peanut allergy published earlier this month.
Another don't miss is the JAMA video featuring JAMA senior editor Dr. Derek Angus prioritizing 5 areas of research that could improve care for patients that are critically ill. Be sure to check out the link to this video in this episode's show notes. And as always, there's a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor's Summary. Thanks, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.